just to make sure that everyone is in the right meeting. And I cannot see anyone outside the committee and presenters being in a meeting. But anyway, if we're joined by any members of the public, we're just recording that this is the meeting of the Patients and Communities Committee. And welcome to everyone to this meeting. Just as a reminder, the meeting is held in public. It's not a public meeting, but it's held in public. It's being recorded for minute-taking purpose, but also I think gets uploaded to the website. So those who are not present today or unable to join the meeting, they can still see what has been discussed. We have a number of interesting items. The presenters are not here yet. Well, I can't see everyone. But again, as a reminder, and I'll remind people as they join in that we had the papers circulated well in advance. Thank you very much to Rachel for organizing all that. So we're going to take the papers as read, and we're inviting presenters to just highlight the key points from their presentations, so that could give us enough time to ask questions and to scrutinize papers and things like that, have a very robust discussion. So I'll appreciate if we stick to that, please. We're not going to go around the virtual room to introduce ourselves. However, please, when you speak for the first time, if you don't mind just saying who you are and the role you have, that will be great. And I'll kick off with that. Again, for those who may be new to this meeting, my name is Elena Deret, and I am the chair of this committee. Lovely, thank you very much. And we'll proceed now to the meeting agenda itself. So apologies, Rachel, I think we have a number of apologies. Please, can we record them?
Yes, we have apologies from the ICB, from Karen Bryant, and from Great Yarmouth and Great Yarmouth Borough Council, Paula Boyce. Just those two.
Thank you. And you said that Emma Ratsam may join. She's planning to join. Okay, lovely. Thank you very much indeed. Declaration of interest. The register, the full register has been included in the pack, so that could be scrutinized. However, if people feel that during the conversation they may suddenly feel that there's a new interest conflict they may have, please can you register that by putting your hand up and state what that is, so then we can add to the formal register, please. Minutes from the previous meeting and matters arising to the meeting was, goodness me, 20th of May, very long time ago. But we have a very good record of that meeting. Thank you so much to Rachel. So I will take accuracy points first, please, before we go to any matters arising. So are there any observations on the accuracy front from any committee members, please? No, I can see negative nods. So Rachel, well done, and thank you very much. All good. So technically we can approve the meetings. Can I see positive notes on this one? Yep, great, thank you. Matters arising. Do we have any matters arising which are not on the agenda today? Yeah. I have one, if I may ask. I know Janice is not in a meeting yet, Janice Shirley, but Frankie, you may be able to let us know, is in relation to Knowledge Anglia website, because we're very excited that was going live. And my curiosity was how we're going to communicate to the public what they can see from their perspective when they look at Knowledge Anglia website. Do we know if any comms have happened?
Knowledge Anglia is largely aimed at health and care professionals. It is a repository for our guidelines and our forms with links to how to access referring in between services. So it's not, so although it is in public, it is not a website for the public. The specific patient and community facing material is held on the ICB website. So there are links to knowledge. It's not hidden, but it's not it's not a specific resource aimed at the public.
Okay, good. It's good to have this clarification, Frankie, also, because that was my understanding of it. But I think when we're talking about our excitement of the Knowledge Anglia website being revamped, there was some mention that potentially public can look at it. So I was not sure about that. So actually it's very helpful what you just clarified, that is for professionals predominantly.
Yeah. It's literally got the referral forms and the criteria and our policies and things.
Yeah, and all that is live as far as you're
aware.
And excellent. Great. Thank you so much. Thank you for the clarification, Frankie. Thank you. I don't have any other matters arising on that. So anybody else? Okay, thank you. So we're going to move on to the action log now. Rachel, are you? You're already onto it. Well done. Thank you. So there were 3 actions on our log, I think. Are they? Just looking at my version. Yeah. So the first one was the update, which is actually on our agenda for today, isn't it? So I'll suggest we close it because we're going to hear from Rebecca very shortly on this update. Is the committee content for us to close this action, please? Yeah, thank you. Lived experience representative, again, is on the agenda for today. So is it okay if we close it? Because we'll be discussing the proposed paper and how we take this forward. Are we content to close this action, please? Yeah, I can't see any hands up. Okay, good, thank you. And the last one is Population Health Inequalities Board update, the risk July meeting, which I think is Mark. Do you want to update us
It's me.
on this one?
Yes.
Yeah.
So again, we've got another item on the agenda today. Sorry, I'm Mark Burgess. I'm the Director of Patients and Communities for the Integrated Care Board. Hi, everyone. Yes, so we've got a paper and I've got an update on risks. So propose to close it here, but there may be subsequent actions we'll want to add to follow, Aliona, if that's okay.
Excellent. Thank you, Mark.
Thanks.
Any objections to us closing this action? No? Great. Thank you. So all 3 actions can be closed now, please, Rachel. And of course, anything else which comes out of the meeting will be added to the action log. Thank you. Okay. Now, this is a new for this committee item is the committee risk register. Mark, I'm sure you'll give us some insight into where things came from and so on. So we have 2 risks currently, aren't we, which has been circulated within the pack, but I will ask Mark, please, to present them so we can scrutinize those 2 risks. Thanks, Mark.
Thank you, Aliona. Yes, and I'll take the brief paper as read, but just to highlight. So we as a committee, there are two risks that we as a committee are asked by the ICB board to own and to oversee and to report back where we have concerns. So in the paper highlights 2 of those. So this is 2 of 8 overall BAF business assurance framework risks that we are responsible for. The first is around the health inequalities and population health management, about meeting the requirements and checking that we as an organisation are doing all that we need to do. And we've flagged the risks around that and the delivery. So there's more detail which has been shared, but that's the summary there. And then the second risk, BAF 06, specifically relates to the ageing population. We know for Norfolk and Waveney that this is a challenge around the services that we provide and commission across Norfolk and Waveney, and making sure that we are meeting the need. And there's a few stats in there as well. So these are the ones that we as a committee are particularly focused on and we'll have oversight of in the coming weeks, months and years. However, the other bit I would just like to say is, as we reported previously, there is a bit of a refresh of how we as an organisation are managing risk. So these are our business assurance framework risks, but we are also, as an integrated care board, looking at our operational risks, some of which we've discussed here previously. And the plan is to bring that here with more detail over the next 1 to 2 months as well, certainly by the next meeting, so that we can capture some of those key operational risks. But I think it's right, and I think it's important. You know, this is absolutely what are we collectively worried about? What are our communities worried about? What are our patients worried about? It's important that we capture that and have the chance to review that as a committee here. So there's still quite a bit of change happening in this area, but that's just a quick summary, Aliona, as a starting point, if that's helpful.
Yes, thanks so much, Mark. Thank you. So I'll go to Frank and then Tracy.
Thanks, Chair. So Frankie, Medical Director. For those of us who are not members of the board, and this may be new to you, I think it's just worth putting in the bigger picture, which is that we have undertaken a refresh of our whole board assurance framework so that it now aligns with our joint forward plan. So there are now 8 risks on the BAF register, and that's why those 2, the increasing challenges associated with an ageing population and PHM and health inequalities, they will be coming here, but equally there's one on maternity, children and young people, one on elective care, one on our financial situation. So the big 8 areas of our JFP are all covered. Though, as Mark says, there are many other things that we are rightly concerned about, other risks to us, which will form part of the operational risk register, which will come next time.
Thank you both. Operational risks, we're going to, I presume, have a threshold on how many will come with, yeah?
Yes.
Otherwise, because I can imagine you have all sorts of operational issues and so on, so we'll get the top ones which are giving us the most concern.
I think a really good example, Chair, is if you take the issue of our RAC hospitals. A huge risk for our system, but not actually any of our strategic priorities. The issue of around a roof, but a huge issue. So that's the sort of level of operational risks that our board needs to be cited on, even though it's not part of our 8 chapters in the Joint Forward Plan.
Thank you, Frankie. Tracy.
Yeah, I just think in respect of BAF01, so just to say, I know because Frankie chairs the Population Health and Inequalities Board, and we do have 2 oversight groups, so the Health Inequalities Oversight Group and the Population Health Management Oversight Group. So we independently then manage subsequent risks that sits beneath the detail of this as well, and obviously escalate up what we need to inform the BAF. So there is that oversight, and again, in line with the change in processes for risk, we are both of us, so that's Suzanne and I, reviewing those, to work along the new process as well. And I think there will be, in respect of health inequalities, there will be some changes because we are focusing as a health inequalities oversight group on healthcare inequalities particularly. So there will be some reflective changes in due course as well, which will come here.
Tracy, thank you. On that basis, from what you just said, a little bit of my reflection on reading it. So, if you scrutinize them, the BAF number 1, it refers to we may have an issue with meeting, the health inequalities. What is the current situation? Do we know exactly what the shortcomings are in terms of us meeting this, the requirements of where we want to be? That's question number 1. Number 2 is current score is 12. Now, from the Quality and Safety Committee meetings, we know that 15 is the break-even sort of point where risks are escalated to the board. This is at 12 and has been already escalated. Do you want to give us any insight as to why we are where we are with this particular risk at 12, but we're looking at it, and I know the board is looking into it, the ICB board. So any reflection on that, please?
So if I start and then others may wish to join. So on the first point around where are we now, Aliona, I think we've got an awful lot of data, awful lot of good data telling us where we are and where our gaps are, where we're weak, where we could be stronger. So I think in that sense, yes, which feeds into the risks that we've highlighted. But again, these aren't issues that we're raising, they are risks that we're rating here. So I think, part of in this new format that we're presenting, we're going to be keeping quite a tight grip of this and looking at what action do we need to take, what's going to change, what are we going to do, and report back on the actions that we are highlighting and taking as a result to try and address those and mitigate those risks. In your first point, the second point. Sorry, just remind me again. The question was around the scoring.
It's about scoring, yes.
Yeah. So that's how the risk is currently scored. But again, month to month, this changes. And we do need to have conversations with more than just the people on this call around that. Why it's a 12 and not a 15, I don't have the answer to, but I'm going to go away and that's an action perhaps for me, Aliona, to find out, because normally it's 15, isn't it, Frankie, for making it to the BAF.
But because this is one of our 8 priorities in our Joint Forward Plan, whatever its risk, it would still be on the BAF. So if it's an operational risk, it only comes to a committee of the board if it's above a certain level. But those 8 areas of our Joint Forward Plan are our board assurance framework, however they are scored. And as Mark says, the score will change over time. But even if it was only a score of 4, it is still a priority for us as an integrated care system. So it is still going to be on the BAF.
Yeah, it's good to have this clarification. Thank you, Beth, because of course it's the first time this committee is looking at this scores. So it's important. Yeah, sorry, Mark.
And sorry, and as Frankie's highlighted, our target for this risk is actually a 4. So that's where we're striving to get to.
Good, thank you. Any questions from any other board member in relation to the 2 risks, please? Because they are firmly sitting with this committee for us to make sure we verify and we scrutinize. So any other questions, please? No. Okay, thank you. So Mark, we're going to see them on every time we have a meeting, yeah? And any other
Absolutely.
risks which are added, they'll be added, not necessarily buff risks, but as we said, operational risks and so on. Okay,
That's it, every meeting, and in our forward planner, Aliona, this will be on every meeting.
Excellent. Thank you very much. Speaking of which, a very quick catch up on the forward planner. We had a discussion about it. Probably I have to apologize to the committee because we did have a meeting about the forward planning, and the forward planner is in draft, is there. We just waited for a few more clarifications. So very soon, Rachel will be able to share it with the committee members. That is just another update from some work we've done a few months ago. Yeah. So apologies for the delay, but we are definitely on the game, so to speak, with it. Thank you. All right, Mark, thank you very much. And thanks to the team working in the background on this. So we are going to move on to the next agenda item now, which is update on children, young people and flourish, including neurodiverse provision. And I think is Rebecca home. I've seen Rebecca joining somewhere. Rebecca, are you with us?
I am with you, yes.
Excellent,
Thanks,
lovely,
Aliona.
welcome.
Hello, everyone.
Hello. Rebecca, do you want to introduce yourself, please?
Yes, I think I know most people on the call, but I'm Rebecca Hume. I'm Director for Children and Young People Maternity and Safeguarding for the ICB, and I'm jointly funded by Norfolk Children's Services.
Thank you.
And I've been asked to attend today to give an update on the children, babies, children, young people around Flourish, but also with a bit of a specific focus on NDD.
Yep.
And I have shared, I hope they've been sent to you, I shared some slides. I was looking back, it was the 22nd of July last year that we came last time, so almost exactly a year ago since we came, and there's been lots happening in that year. So I'm just going to share very quickly the slides. I think that was what was requested of us. Thank you. That we share our own. Can people see that?
Yep, all good.
Lovely. And I hope I've got the right slide set there because I've got a couple up at the moment. Okay, so just, and I'll take it that people have had a chance, but just I went through as a bit of a reminder of you know, the profile, a bit of contextual information for children and young people, that nearly a third of our population are under in the 0 to 25 category. So it is a big cohort that we're talking about here. It's not a small number of people, and obviously lots of opportunities for early intervention and prevention in this cohort, and a bit of data around the numbers of state-funded schools, children in care, etc. Shows it's a massive group that we, you know, lots and lots of different providers and partners that we need to work with to make a difference in this space. We were asked to update with Flourish for those that don't know, and I would hope that everybody on the call knows and has it ingrained what Flourish is, and it is our framework and a system ambition that's part of our entire system. So we've got everybody signed up that's working with children and young people to this framework. It has proved incredibly helpful because when we're looking at designing services, commissioning, we do it with Flourish in mind. So what does that mean for family and friends? What does that mean for learning or opportunities for young people? So it does give us something that we all share and can work around together. And again, a bit about what that means for us, prioritising the voices, needs and ambitions of children and young people, which I think is really important. In our joint forward plan, we do have some specific ambitions for babies, children, young people and maternity, and there are a number of those there. We have added NDD, you'll be pleased to know, is formed in our second iteration. We have now added a specific work stream around NDD as well into that this year. And a reminder again that there is a specific core 20+5 ambition for children and young people as well. So we need to make sure that we are really focused on what we can do in that space. And NDD sits in that very widely as well. We've chosen that as our plus, those who might be neurodiverse or have SEND. one of the newer things that's come on stream, it's one of our ambitions in the Joint Forward Plan. It's part of the work is to develop a system collaborative. And that's really motoring now. It's a commitment from the system to work together with key partners joined up who are delivering services for children and young people. And it is about us accelerating the progress, both for the Children and Young People Strategic Alliance and Flourish framework, but also for our Joint Forward Plan. So we do meet regularly. We're very lucky. Tricia joins as the exec on that board alongside Sarah Tuff, Matthew Wynne, and now Caroline from the NSFT are the key exec leaders on there. So really committed to working together for children and young people. And the key areas that we're looking at are needs associated with neurodiversity and mental health, as you would expect. The two overlap a great deal, so they're not by any means separate, but because it's such a huge programme of work, we have actually split them for the purposes of the system collaborative work. Currently, what we're doing at the moment, where we're at with the collaborative, is we are developing a case for change, a system-wide case for change for both those areas. So it is about what is everybody's role in making a difference for children who might be neurodiverse or with a mental health need, because it certainly shouldn't just sit solely within health to deliver the change that's needed and make a difference. So those cases for change are being developed at the moment. And they're not a business case. It's much more about what existing resource do we have, how do we align it, and how do we make sure that we get best value and best outcomes from that work. So they'll probably be shared with the system at a fairly near future. So picking particularly on neurodiversity, which we were asked to do, we've given some. These are the kind of outcomes that we've agreed in the system collaborative that we want to be working towards. And there are lots, you'll see there are lots and lots of different work streams that are pulling together to try and understand what are the opportunities, how do we work to deliver those, what barriers might be there, etc. And they are now all these areas that you'll see in these next task and finish groups that I've shared are being brought together to come up with a system approach to how we support neurodiverse children. There's also obviously picking up the areas that we're already commissioning. So what is in the system already, and what do we need to make that work more effectively for our young people? You'll also be aware that it is we do now have a BAF entry for NDD alongside our mental health entry that's been there for a long time, and they will sit very squarely under the Children, Young People and Maternity Ambition now. They had previously been, the mental health had sat with mental health, it's now been moved across on the BAF to that Children, Young People's commitment. Sorry, dog barking. And we also, they're included on the Quality and Safety Committee risk registers as well. We bring an update on those on a monthly basis. We do have a huge challenge ahead of us with our diagnostic backlog, but we again have to remember that it's not just about a diagnosis. We need to think differently. I'm encouraging people to actually try not to think of the word diagnosis. It's important that we confirm what a young person, so I think confirmation is a much better word than a diagnosis. This is a young person's how they are in the world, how they place themselves, their presentation. It's not a disease. It is a presentation. So we need to move away from that very medicalised approach where we talk about a diagnosis to confirming for young people and their families. So we've got lots of pre-diagnostic support in, post-diagnostic support, which we need to build, but we're also building digital library. We've got a pilot project, which is the Partnership for Inclusion of Neurodiversity in Schools, which we're doing a targeted approach in, and a test and learn project with some primary schools, both within Norfolk and within Waveney. And we've now got a provider framework which assists us where we've got young people exercising choice, but also it gives us some options if we have any resource that we can target for families to get a bit of extra capacity in the system. Yeah, and we have done lots of changes on our referral process. We've got a transition project group in place. And lots of different work where we're developing a system approach. So I think I'll just go to any questions and I'll stop sharing, and I'm happy to take any questions from people. Sorry, I've galloped through that. There's a huge amount of work going on and it's very difficult sometimes to know where to target a presentation. Thank you.
Rebecca, thank you so much. I think you've targeted it just right, because the NDD has been playing on people's mind for a while and you just picked up the right points. I'll go to Kathy. I have a actual example from the weekend. I'm just going to highlight to you how actually things work or not, but very timely. It's patient's experience type stuff. Yeah, Kathy.
Okay, thanks, Rebecca. That was really enlightening. Actually, I've got a couple of questions, if I may. One is about parents. You know, if there's a 5-year waiting list, and I know you're trying to reframe it so that it's not all about diagnosis, but a couple of parents that I know who are on the waiting list, that's their focus, if you like. It's when we get the diagnosis. And I just wondered how much education it is required for parents in this, because I just don't hear that, and I know 2 people who are on waiting. And my other question before I answer that was, in schools, I know Norfolk County Council are not going to be funding some of the special needs anymore, teaching assistants. Does that impact, or do we fund any assistance in schools? Because you had about schools in there.
Okay, I'll take the first question around understanding for families. I've got friends and families on that waiting list too, and it does become very much a focus, the diagnosis. But actually, there is a real need to shift to understanding what the young person's needs are. This is a needs-led service, and the diagnosis itself, or the confirmation, as I'm going to call it, won't change what the young person needs. It can be helpful to some families, and it can more be helpful into adulthood, if I'm perfectly honest, because it allows, particularly when people go to university, it does allow them some support if they have a confirmed neurodiversity, that allows some support that they wouldn't necessarily be able to get without that confirmation. So there is a reason that young people would need that, but actually it's much more important to identify what is that individual child's needs and how can we work together to deliver it. We have a lot of work to do. I say we, as the system, have a lot of work to do with our education settings, because in many there's still a perception that they can't begin to meet the needs unless a young person has a confirmation, or unless they have an EHCP, and that simply isn't true. But they're quite a difficult group to work with. You saw that we have 450 different school settings in Norfolk and Waveney, and that is quite challenging, particularly as they don't come under one framework. You might be working within an academy, a group of academy trusts who have other priorities that they're working in. There is quite significant funding for children with special educational needs and disabilities, and even those who don't have a confirmation, they actually can get additional resource into schools. Schools need to make that assessment. So the work that we need to do is with families. There's a lot of communication, and that's part of this case for change, Kathy, because it is that how do we, as a system, understand how we communicate with families, what language should we be using, but also with schools. It's a really big challenge to work with those education settings.
Yeah. Okay.
Thank you. Thank you, Rebecca. Thank you, Kathy. Tricia.
Hi, my name is Trish Dorsey, and I'm the Executive Director of Nursing for the ICB and the Senior Responsible Officer for the ICB Board for Children and Young People. Oh, that was a mouthful. Thank you, Rebecca, for the presentation, because it was putting across a lot in a very short time frame. I think the committee should be aware that the work that's going on with our local authority partners in this space and the children's services providers has been second to none, actually, in the spirit of collaboration. But there is an absolute recognition that there is so much more to do. And particularly for those individuals who are sitting on waiting lists at the moment, that is certainly not something that we are comfortable with at all. I think Rebecca's point was extremely well made about a misunderstanding about what the diagnosis might bring for the family. But there is also something that a diagnosis is required for families to benefit from. So it's finding that position where we've got people who are referred appropriately, then not having to wait a disproportionate amount of time. So that waiting well piece is something that the collaborative is considering. I think the other thing is all of these conversations are very much focused on what does it feel like to be a parent, of a child on that waiting list and not sure where to turn and where to get support from. So the team in collaboration have been doing some really excellent work with regards to signposting and advice as to how to manage some of the challenges that those families may be experiencing. So I think that's a good piece of work going forward. And then finally, Rebecca articulated about the relationship with schools. So we have another collaborative, which is in safeguarding space, which is the police, the local authority and health. And we are absolutely committed to bringing our colleagues from education into that forum because it needs to happen, because children, unless they're absenting, spend the bulk of their day within a school environment. So that has got to be an area where we're able to provide mental health support and advice and guidance to those children as well. So the relationship between ourselves and education, I'm hoping in the next 6 months to a year, matures further, so we can actually have better health responses into those environments. Thank you, Aliona.
Thank you, Tricia, and thank you for bringing it all together like this. Would you mind if, Tracy, before I come to you, if I just give the example, what I was mentioning at the beginning, because actually it brings all these 3 points together. So a family who...
As long as it's not too identifiable,
No,
Aliona, then
It
that's
isn't.
fine.
It isn't.
That's fine.
Is a family who is not on a waiting list for confirmation or diagnosis, is a family who is very content with just having a support plan for the child. Child is in school. The school have done a sterling work at actually putting that support plan. Well, I'm not sure I've seen it, but it's called a passport. Rebecca, I'm sure you'll know better than me what that passport does, but it could not have been clearer. It describes exactly what the child likes, doesn't like, what may trigger what. So very good piece of work. And if that is being implemented across all our schools, that is, for me, is big commendment that we've reached that point. The downside of that was that whilst all that is in place and the family is well known to the school and so on, there was an incident when the child became quite upset by something which was unfair and the child's perspective, and went to the fence to kick the fence, because that was a way of dealing with the situation. What that resulted in, the child being told off by the same people who were involved in putting the plan together, and the parent being called to come and pick up the child who's escaping from school. The child was going nowhere, was just by the fence trying to manage the emotions. And I thought, it's just such a wonderful plan in place. It's all very clear. Child was involved in putting that together, and then the application didn't quite mirror it. It could have been just an incident, different staff members on shift or whatever, but nonetheless, we're doing all this work, but unless it happens on the ground and unless the experience is what we expect the experience to be, then it's sort of paperwork. So my question really, it had a point, all this story. It's true story, happened just before the weekend. The question is, how are we ensuring that actually on the ground, children and families receive the experience we want them to receive based on all this work we are doing, please?
So
you're probably closer.
Yeah, I think we could come to you every day of the week, several days of the week, several times a day with stories very similar where things like that are happening. And we it's just dogged determination. I think there isn't a secret plan to this. It is just continuing to repeat and repeat and repeat. It's not about the children having to adapt to their different environments. It's about us understanding that we don't have one single environment that fits every young person any more than we do any older person. You have to be prepared to kind of understand those and deal with young people as individuals. And we have to keep telling that message. I don't think we'll ever get to the point where we don't have to keep repeating the need to individualize things. And it's really upsetting when you hear those stories, when you know a great piece of work has happened and then it's just not followed. I think that happens in the adult space as well, sadly, where we're talking about those with learning disabilities. They'll have a great plan and people just don't follow it and don't read it and don't enact it. So just please to everybody, anyone who has an ear to listen, we must change. It's not about children changing, and keep repeating the message.
Thank you. In fact, this child actually enabled themselves based on the plan they have. Yeah. So they've done what they say. I will just go aside somewhere
and go and find a way to manage.
Yeah. So the child actually did follow the process. But anyway, it just brings to life when we look at those things, because I know how much work has happened in the background and how much we're striving to do the best we can. It's just that sort of we need to make sure it happens to the end. Yeah. Thank you, Rebecca. Tracy.
Yeah, thank you. So that's really, really good and helpful to see, Rebecca. A huge amount of work underway, I can tell. And I know certainly, although the waits are very long still, there's such a lot of kind of progress and support that's in place, I think, for, you know, young people, families. So that's really good to hear. Kind of my question, you touched on the health inequalities lens, and that our children with neurodiversity, our young people, are one of our plus groups, as are our adults as well. We've taken that approach across Norfolk and Waving, which is really positive. Just thinking about the experience and access of our core 20 groups within that cohort as well. Is there any work underway that's kind of looking at it from a health inequalities lens in that perspective that the teams have been doing that you know you could highlight perhaps? Because I know we've had discussions certainly around the Flourish framework and the core 20 approach as well as plus, but just thinking, is there anything specifically around those other kind of wider determinants focus at all?
Yeah, so I think that's the main reason that the collaborative came into being, was for us to be really targeting resource and thinking about health inequalities. I think every piece of work we do, we're now trying to address that. We recognise that the outcomes for children who experience, you know, that target population of the core 20+5, they're going to be higher numbers in all of those groups, including smoking in pregnancy, higher numbers of neonatal deaths, all of those kind of things. So it's not just for children, it's in that antenatal period as well that we need to be doing more work, because the outcomes are poorer for all those groups. So I think it is about us recognising that and not thinking that actually we have to have a generic service across the whole system. We do need to really start targeting that resource, think where are our populations that we can make the biggest difference, and try and go out to those. So when we're putting in place mental health support teams, we've got the school and community zones that we're working on. All of that work is much more about addressing health inequalities and understanding for each of those smaller cohorts where is the most value going to be added, and where can we make the biggest difference for families. It's fairly, you know, it's nascent work, Tracy, when we've got a lot more to do. But actually, I think that this has been really powerful to us to start thinking about inequalities. We know, you know, thinking about the Youth Justice Service as well. Again, that's an area that sits within our CYP team. We have this duty to work in the youth justice space. We know that those young people will have higher percentage of young people with neurodiversity, with speech and language difficulties, who've been looked after children. So all those areas of inequality are really, so we're doing some more work around what can we do for that specific cohort? What can we do for looked after children who are another group that experience inequality? So yes, lots of work in that space.
Thank you, Rebecca. Thank you so much. Any more questions for Rebecca? Rebecca, a big thank you from all of us for all the work. Please, can you pass our appreciation to everyone in the background who are working on this? And yeah, good luck with the next stage of getting closer to the targets you have.
So can I just add one final thing, Aliona? I think the area that we all need to think about is that transition space as well, because I've just mentioned youth justice as an example, but also when we think about continuing care and CHC, children who might be one day exploited, the next day can become a perpetrator just because they hit their 18th birthday. And so we need to think, what are we doing in that space around? So I think that's for the future, but just all of us just to have that in our minds, what we're thinking about in that very fragile age between 18 and 25 to do things differently for our young people.
Rebecca, thank you. Where are you capturing those so we don't forget? Where that gets recorded in our plans? Because we're up to 25, there will be mention of 20. We've got a transition network up and running, and we're putting a transition post within the safeguarding team, for example. So I think other parts of the system, there's just to be a piece of work in safeguarding. We're just doing a review of transitional safeguarding arrangements. So lots of it will be picked up in that 0 to 25 space. So we think about it in SEND as well.
I just like to keep, because I know we cover all age ranges in this this committee, so I think it's quite important to remember that transition, and transition also from at the older adult age as well, from working age to older people. That's also a really challenging time. So I think transition needs to be really thought of quite carefully.
Indeed. Thank you so much for flagging that up, Rebecca.
Okay.
Thank you. Thank you again, and we'll see you
Thanks.
soon.
Nice to see you all. Bye. Bye.
Thank you. Bye. Okay, we're going to move on now to the lived experience representation proposal. Karen or Hayley, or both, are you on a call?
We are. Hello.
Excellent. Welcome. Over to you, please.
Thank you. I'll just do a very short introduction. Hayley Sharman is also here with me, and Hayley's done all of the work on this, so I don't want to sit in this committee and take credit. And also, I think it's very important that people that do the work within the organisation do get a chance to present at these kinds of things. So Hayley's here. What I will just say is I think this has been actually a very interesting piece of work, because we've done a bit of fact finding since we last joined you. As you remember, we gave an outline of what we wanted to do last time, and now we've had time to actually do some more work on it and speak to relevant people. And what we have found is there was a lot going on in this space that actually even we didn't exactly know about. So it's been really helpful for us as a team. We've summarised some of it in the paper for you all, and then we've got some proposals that we hope will you'll be agreeable to, that we can then move forward. But just to say, I think it is quite an exciting space, and there's quite a lot already going on. So it's great that we're able to tap into it. So I'll hand to Hayley, who I think wants to make a couple of points, and then I'm really happy to take your questions. Thank you so much.
Thank you,
Thanks, Karen. Thanks, Karen. Thanks, Aniona. And yeah, thanks for having me here today. So yeah, as Karen said, the paper has kind of come off the back of a conversation at the last committee meeting around lived experience representation at this committee, and how the original plan of having sort of two representatives isn't actually viable, and it wouldn't be kind of fair or a meaningful way of getting experience into the committee and the work of the ICB. So what I've done is kind of gone back to sort of basics, really, kind of gauge what we are already doing in the system, what our partners are doing, and also what we're kind of doing across the border in Suffolk and then Waveney. And so that's kind of all been kind of recorded in the paper. And I think the proposal we're bringing to you today is that we continue working with our partners, with Healthwatch, with local authorities, and with these really great patient groups and organisations who have the relationships and are working with people who have that lived experience. And we start to involve those groups more strategically. And I say that me thinking about the way that the committee forward plans and thinking about how we can bring lived experience in a way that is going to be meaningful and fair, but also isn't kind of tokenistic and isn't kind of bringing someone in just for the sake of it. So I think, Aniona, your forward plan you were talking of earlier is really key to this. And again, the kind of forward plan of the ICB and upcoming work, engagement opportunities, involvement opportunities will be key to this too. And just looking to get that kind of meaningful involvement in the committee. And as part of that, we're also looking at having so a standing item on committee, maybe sort of once a quarter, looking at that forward plan and making sure that kind of we can align that so that it fits and is meaningful and is, you know, it's beneficial for everyone across the system, and especially for those patients. We already have a patient sort of experience or a patient communities video that goes out at our board meetings, and I think part of our approach would be to bring those stories to this committee as well. So again, people who are sharing their lived experience stories with us, they're not sharing them more than once, they're not having to repeat themselves, and we get to share those stories far and wide. So I think this committee is a really good mechanism to share those stories as well, and not just have it at that kind of board level, and kind of get it out there more into the system, because, you know, lots of system partners at this committee and lots of ways that we can hear what people, patients and lived experience representatives are saying, and get those real life experiences into the work of the ICB this committee. So I'm really happy to take any feedback, any thoughts, and yeah, anything anyone's got to say. Happy to take any questions. Thank you.
Haley, thank you so much. Thank you to you and Karen and anybody else who helped with looking into what we're already doing. And you're right, I know we're engaging a lot. And I think it's just the time has come for us to learn from what we're engaging and what we hear. Yeah. Couple of questions from me and maybe reflective sort of suggestion, if I may, please. Completely agree, because there's 3 recommendations really in your proposal to work closer with Healthwatch, of course. I would like to add to that the VCAC Assembly, because the Assembly will have in its forum, so to speak, various forums representing various groups. Yeah. So I think if we want to reach people, then VCAC Assembly will be a very good way of doing that. So it's sort of complementing the engagement with Healthwatch.
Absolutely.
In terms of dedicated item on Patients and Communities Committee, what I was and the videos, if I take those 2 from sort of where I'm sitting and thinking about it, what will be good when we have deep dives or we explore topics? It will be good to have people, or we have a video related to that on people's experience, or we have people with that experience coming to that topic to help us discuss it, if you see what I mean. So I wouldn't want us just to have, let's have some topic here for lived experience only and discuss something else entirely. I think it would be good if we actually connect things. So then we can get
absolutely.
the first-hand experience
and
of people related to that.
Definitely. And I think that's definitely kind of a vision that we've kind of, we've kind of talked about. I think, like I say, it needs to be relevant, it needs to be appropriate, but also something that someone could have a meaningful involvement in and actually, see changes being made. So I think that's a good point.
Technically, in terms of the fourth planner, it will be every meeting of this committee, because we'll have topics to discuss at every meeting where we most likely would like to have the experience of people with lived experience in that area. So I think if we just think, and again, is planning together with Rachel and Mark and Karen, just to make sure we can actually achieve that, because of course there's only 2 months in between, and we need to make sure that people get appropriate engagement rather than just being pulled in because we need the person's lived experience. Yeah. So I think good planning in advance, it can prove to be much better than just having 2 people sitting on a committee, because we will be targeting who is coming and what, being very specific experience we are looking for to make sure is very meaningful. So that would be just my observation. It's not different to what you put, but it's just linking back to agenda items, yeah, and making more cohesive as such. Mark.
Thank you, Alona. Yes, and thanks, Haley and Karen, for the paper. I completely support the proposals and the recommendations in there. Haley, you mentioned meaningful, not tokenistic engagement and listening. I completely agree. I know I've talked about that many times before, that I think what will be really important to do is demonstrate as a committee that where we've listened and where we've acted and what's changed as a result. I think that will be critical, as you've highlighted in the paper, and really involving the right people. Just as a practical example, last week, a few of us, Karen was there too, we went up to Cromer. There was an event to discuss Benjamin Court up in North Norfolk. And people were very honest and very open and shared their thoughts with us, shared their suggestions with us. And actually what we're doing now as a result will change, because, the things that we're going away to look at that we perhaps wouldn't have done beforehand. So I think it's going to be really important that when we do this, we just keep that check back as to say, you've said and we've listened and this is what's changed as a result. So, and I know that's core to your proposal. So thank you for that. Really supportive.
Thank you, Mark. Tracy.
Yeah, apologies earlier, I didn't say who I was. I'm Tracy Williams. I'm the clinical lead for Health and Equalities, Inclusion Health, and the advisor for Norwich Place, and I chair the Norwich Place board. So I think that's really positive and really, really good to see that. And I think, we all really support that engagement. It needs to be really meaningful. That's really positive. And I think having that kind of, as you described, Aliona, a bit of a deep dive and having those kind of experts within that come when we're doing that'd be really helpful. I do think there's something also about you know, the early stages of co-production, the early times of, I'd like to see that we're doing that we are having that voice when we're actually designing, when we're producing, when we're commissioning. So through the commissioning cycle, basically, that we've got that built in. And I think it'd be helpful for this committee to see that we are actually doing that. We're fulfilling those requirements as well. How we do that, I'm not quite sure, but I think this is the right way forwards.
Tracy, thank you so much. I must admit, I feel much more comfortable with the suggestions we're discussing now than what we struggled for the last 18 months. So we're definitely heading in the right direction. Tricia.
So absolutely, it can't be tokenistic. Otherwise, what are we all here for? Because we're meant to be really representing our communities. I'm just sitting here reflecting. It's my first meeting, so for that reason, I'm just listening and absorbing today, I hope. But there is an opportunity here to think about the cohesiveness between this committee and the ICB board with regards to that lived experience piece. Almost as if it came through here and then it could go to the board and we could put recommendations to the board about what could be done differently as a result of it. So I welcome the steer that we need to do a little bit more thinking about it, because I think it is an incredibly important initiative to take forward. So I'm happy to be included in those conversations outside.
Excellent. So can we add Tricia to the list I mentioned earlier, please? Thank you very much. Haley, I can see your hand up. Can I ask, hopefully it'll be the last question from us, I'm just mindful of time, is the connection to the people and communities approach, because this committee receives updates on the approach, but of course that's exactly what we're supposed to be basing our engagement on. So it's just, I'm sure you looked at it, but it's just for me flagging up that if we can just make sure that
I was just going to mention that, Aliona, because I remember you did have Emily Broadby updated working with the people and communities approach last time. So of course that will be updated, you know, if his approach is agreed and updated with how his approach develops. But I was just going to agree as well with what Tricia said about the conversation around how feeding lived experience through this committee into board, I think will only strengthen that voice and the importance of lived experience across the whole organisation, ICB, and the whole system. So that's something that sounds quite positive. Thank you.
Thank you, Haley. So Tricia, your joining is quite timely because this is the first time we're looking in details how we want to do this differently to other regional planners. So everything is just slotting, I think, for me, into place now. It took a bit of time, but sometimes it's better to take time and do it right than just rush it through and not achieve very much. So a big thank you to the team who looked into all of this. For the proposal, can I have the committee's approval in principle that we're heading now in the right direction, and ask that we have an update at the next meeting, just post conversation of people we just mentioned, so we can have much more robust plan now. And maybe we trial at the next committee one of the topics where we can get service users involved in whatever we're going to explore. Can I leave that in your capable hands, please? It needs to be something we can actually achieve, because it'll be good to test and trial and see how that is going to work for us, so we can learn from it and do better next time. Is that okay? Can I have the
we're really
sorry, Karen.
We're happy to do that. I think it'd be good now if we move it along and actually organise, you know, what we've said for the next meeting, so then you can see how it works. That would be great. Thank you.
Lovely. A big thank you again for all the work done on it, and we look forward to hearing next time where we're at. But well done, and thank you. Okay, with a little delay, apologies, but it's good discussion, so there's nothing really to apologize. But I will come now to our two Health Watch colleagues. I think we have two reports, and one of them is a video. Alex, are you happy to start us on that topic, please?
Thank you very much. Just to reassure people, we had a query today about some of our case studies being patient identifiable. I want to assure you people that they're not identifiable because we changed names and places. And we also showed it to our board members just for a little bit of double checking. So they're all agreed. So the report stays as is. Rather than have me babble on, with the magic of technology, we sent Rachel a video, which hopefully she will be able to know how to work, because I definitely won't. So it just gives an overview of the last year.
Yeah, thank you, Alex. I'm going to warn the committee that we're going to overrun, so apologies. We'll have to bite a little bit into part 2 of the meeting, and Mark, you'll have to speak fast for that. Thank you. Thank you, Rachel.
The value of listening. It's at the core of what we do. Hearing from people about their health and social care experiences helps inform our work. Whether it's engaging with communities across Norfolk in care or community sites, helping people who call in to us, or working with different communities to understand their concerns in more detail, we need to listen to what people say and pass those views on to those who shape our services. Our role is to analyse and spot trends, act on feedback to drive change and improve services, and help make a difference to people's lives. We do this by working in partnership with care providers, the government, and the voluntary sector. So just how many people have we spoken to over the past year? 2,540 shared their experiences of health and social care with us. 282 came to us for advice, and our team carried out 101 engagement visits to GP surgeries, pharmacies, libraries, care homes, community centres and community events. In addition, the entire team spent a week in each of Norfolk's 3 acute hospitals for the 3 Hospitals 3 Weeks project. In total, 5,417 experiences formed part of our targeted engagement and projects for the past year. As well as the general engagement we do, we also carried out some targeted work too. Because of concerns around pharmacy care, we visited pharmacies and dispensaries around the county, hearing from over 1,000 users and 46 professionals. While people were generally happy and thought they were treated well by staff, we did recommend better communication between GP practices and pharmacies. And pharmacies were also encouraged to talk to patients in multiple ways, including social media and text messages. One of our major engagement projects for the year was 3 Hospitals 3 Weeks. It saw our entire team spend a week each at the Queen Elizabeth Hospital in Kings Lynn, the James Paget University Hospital in Galston, and the Norfolk and Norwich University Hospital in Norwich. We visited as many wards, clinics and departments as we could, speaking to patients, carers, visitors and staff. Most were happy with the care they received, but there were concerns about waiting times, cross-departmental communication and parking. Talking of reports, we also published many more linked to our My Views Matter project, which saw us visit residential care settings for those with learning disabilities or autism. As well as publishing individual reports based on the feedback we received at each site, we also pulled together the key things we discovered for a full report. We did hear a lot of positive feedback, and most people felt they had an avenue for ensuring their voice was heard, something that didn't happen at Corston Park, the site which triggered our work in the first place. There were some areas for improvement though, including the building of stronger relationships between staff and residents. Ensuring managers were well informed and engaged in the life of a home. Trying to make living spaces as personalised as possible for residents. And ensuring relationships are maintained for those residents with both their parents and immediate family and older friends. Other project work we got involved with through the year included getting the views of communities around proposals for a major trauma centre to treat some of the most serious injuries here in Norfolk. Finding out how easy people found it to engage with the Care Quality Commission if they were homeless or of no fixed abode. Discovering how easy people found it to access long COVID support in Norfolk. and the experiences of those transitioning from being looked after as a child to an adult within Norfolk Community Health and Care. The team also gathered feedback from people on the care they received at the Benjamin Court facility in Cromer and carried out a training programme for the governors at the Queen Elizabeth Hospital in Kings Lynn. Our phone lines remained busy. Around a third of the inquiries we received were linked to difficulties accessing NHS non-emergency dental care. Because of this, we're gathering people's dental experiences over the spring and summer before holding a dental summit in the autumn to look in more detail at those issues. We also helped people with a wide range of other questions, which include helping to access bereavement support, helping a 16-year-old access urgent help as he was homeless in Norwich, advice on the rollout of prescription drugs or other treatment, difficulty in getting a prescription, helping a mum get support for her 8-year-old's anxiety, and even working with a surgery to improve its signage following patient feedback. Sharing public information and advice is also important, as well as our social media channels and our fortnightly newsletter, which reaches over 5,000 people. We also created content to help people understand what the new PSUF system is around looking into patient safety incidents and how people can help with this process. Continue to highlight the availability of free NHS health checks for the over 40s. Shared information about the Carer's Identity Passport, which helps unpaid carers identify themselves in health and care settings. And also explained how people can now access their GP records online if they wish. The listening is going to continue for the next 12 months as we continue to engage with those with serious mental illness, their families and carers about their experiences. Our team will also continue their focus on social care, trying to talk to even more people in care homes to discover what they think about how they're looked after. Our project work will continue around accessing care digitally in conjunction with the ICB. And we're also going to be working with the Queen Elizabeth Hospital in Kings Lynn to help with the recruitment and running of their new youth council for 18 to 25-year-olds for its first 12 months. Whatever you want to raise with us, we're here to listen and gather the feedback of people across Norfolk about their health and care experiences, help them find ways of obtaining further support if they need it, and make sure health and care leaders hear what we're being told so they can shape future services. So please, keep sharing your stories and experiences to help us prioritise our work and help health and care leaders prepare for the future to provide the best services they can for you.
Thank you. That saved a lot of me babbling on, really. So any questions?
Thank you, Alex. Lots of work is going on, isn't it? Please, can you reassure us that you do have the right line to those healthcare leaders you're referring to, where you can pass your information to and make sure that it's taken into account and changes are happening?
Yeah, we can. And recently we undertook a little project looking at all the areas of work that we had done since inception back in 2013. And it covers about, I suppose, 98 individual reports, all of which had recommendations. So we wrote to everyone who had some report sent to them. These are the big providers, really, not all the care homes we visit as well. And asked them what they had done with our recommendations. And out of everyone we contacted, at least 3 of the recommendations we've made in our reports had been actioned. In many instances, all the recommendations had been actioned, and we did a double check just to sort of, we were a bit sneaky because you never believe everyone all the time, so we actually went out and did a double check and visited places as well and actually asked patients. So I think we've been very lucky, and it's all down to me being surrounded by people who are actually excellent at what they do. I cannot take credit for this at all.
Okay, we'll not give you credit then. Absolutely. Alex, thank you so much. And yes, very much understand the benefit and the value of a good team working in the background. But it's important that that work gets to the right places too, and we impact change. And I'm very pleased to hear that you're sort of going back and saying, let's see what has been done or not, as it may be the case. But well done. I can't see any hands up, Alex. But I can see a comment. But what I will say on behalf of all this committee, Kathy's hand is going up now, is that please can you say thank you to all your team for all the work, and do keep up the good work you're doing, because it does benefit our local population. So thank you. Kathy.
Thank you.
Thanks. So I wasn't going to ask my question until after Andy had done his annual report presentation, but it doesn't matter. The numbers, so the numbers contained within Andy's report are vastly different to the numbers contained within your report, Alex. And I just wondered, is it a different way? Are we counting different things? I think in Andy's it says something like 25,500 queries or touch points or whatever, and then yours was 2,500. And I thought, well, that's a massive difference. The two counties don't have hugely different populations, do they? So are we counting different things, or do you know, is it vastly different makeup, or what do you know?
I can't comment on Healthwatch Suffolk because I don't know, and I would have to respect Andy for that. But in Healthwatch Norfolk, these are things that we've actually dealt with immediately. So if I'm looking at sort of people who have contacted us, we have over 3,500 hits on our website every day, for example. So if you start multiplying that by 5 or 7 by 52 weeks, you start getting fairly substantially high numbers.
Right.
But how many of those are just people stumbling across us, or actually sort of flicking in for 10 seconds and then actually it's not what they want and going out? We're not good enough to actually provide you with that information yet.
Well, the word integration springs to mind, so I'll go to Andy for him to potentially demystify that, Kathy, for us. But it'll be good to actually look into each Healthwatch, how are you measuring and so on, because particularly the area where we're sharing, it is good to have a common understanding on what we're looking at. So Andy, may we come to you, please? I know you're there somewhere.
Hello, everyone.
Hello. Hi, Andy.
Can you see me?
No,
Aliona?
not at the moment. No, but
No?
keep talking. Yeah, I can't see you, but please.
Okay.
I can see you, Andy. Yeah.
Okay.
You need to put another 50p in, Aliona.
I can see you now. Thank you.
Oh, good. I'm not here to report on our annual report. I'm happy to do that next time around, but we weren't in a position to do so today. The annual report is public knowledge now, because all Healthwatch had to publish it by a certain date, as we do every year. The only thing I will do is just to cover the point that Kathy made. I think the figures that you're talking about, Kathy, are I'll just share it in the chat. You should now. No. Very slow, isn't it? Try again. Right. You should now have access to the page that refers to our report. And the numbers that you're talking about, if you scroll down a little bit, you'll see the bit that says our work in numbers. So the 1,006 are the people that contacted us either by email, by telephone, by letter, and required signposting. Now, this is a legal, a statutory requirement of a local Healthwatch to provide such a service. We're not there to provide support for single issues that individuals may have or families may have, but we're there to explain their situation and who to go to when and in what order and what to expect, that kind of thing. There are nearly 300, I think, each year organisations that are signposted to by us in Suffolk, and that's probably very similar wherever you go. The 20 plus insight reports, these are projects that are either core funded through our core budget or mostly commissioned work. The 25,000 plus research respondents are associated with those 20 reports. The 23,000 reviews now recorded online, that's the history of our feedback centre going back to 2013. When Local Health Watch came about. So we can go back and find themed aspects of what people have said over time and how it's varied. Because we have that many over that period of time, it's qualitative and quantitative. So that hopefully that explains the numbers. But
yeah, it does.
our approach, when I do talk about annual reports, is more about impacts. So if you do find time to read the report, or the summary report at least, you'll see that's the way it's designed. I was just going to mention, I'll go on, Eliona, go on.
No, I'll let you finish. Thank you.
I was just going to say, what I put in the chat is what's been happening this last few months in terms of engagement and community work. So one of the things we had to do in the last year was reduce our community development team, engagement team, because of the core budget restrictions. So Kerry left, and one of my colleagues, Elizabeth, is now responsible for Waveney and East Suffolk, and she's explained where she's been most recently. And then the second part is a series of projects that are soon to launch or have just about been launched that cover the Waveney area. And these are all commissioned pieces of work.
So my question was on the back of that, Andy. Thanks so much, because it is a good list there and very interesting topics you're going to look into. So my question is, as far as you're concerned, do you have a clear line of where you can take that information to related to Waveney within the Norfolk and Waveney system partners, so we can influence any thinking based on what our population tells us, please?
Not always. It depends on the subject matter. There are some go-to people like Rebecca Hume, like Karen, like Mark, and Rachel. But then when there is anything specific, maybe a theme that we haven't covered before, and if I'm looking at the projects that are coming up, spinal care, for instance, then it might be new and we would need to seek out some individuals. But we know where to go to ask the question, at least.
Good. That's the main thing. Ask the question. I'm sure colleagues will find the right people for you to talk, but we just need to sort of now stay focused on whatever people are saying to us. We need to think about it, take into account, and bring to the people who actually can affect change. So, Andy, thank you so much for that, because it's lots of work going on, and we only want to ask people if we're going to do something about it. Otherwise, we're just wasting everyone's time. So, well done, and good luck with the forthcoming work. And yeah, please make sure that the findings are taken to the right people who can impact and change. Thank you, Andy. Andy is in a frozen state on my screen, so I have no idea if he's trying to say something or not. But
you've all frozen on me as well, so I can hear you.
Good, Andy. Thank you very much indeed. Thank you. Moving on. Oh goodness me, almost 15 minutes late. I'll go to Rachel and John with the spotlight on Great Yarmouth and Waveney Place Board.
Thank you very much, Eliona. I'm going to help you with the timekeeping, Eliona, because we've circulated some slides. Don't propose to go through them. I think everybody does know me. I'm Deputy Chief Exec at the James Paget, and I chair the Great Yarmouth and Waveney Place Board. I'm going to steal Alex's comment earlier on about being surrounded by brilliant people. One of them is with me here today, and that's Rachel Hunt, Head of Integration and Partnerships for Great Yarmouth and Waveney. what I was going to do is just talk you very briefly about what we're doing in the Great Yarmouth and Waveney Place Board. Rachel's going to give you a very quick example of some of the areas we're working in, and then I'm going to throw a challenge back to this committee, if I may, in terms of how we can do better in the future. So Great Yarmouth and Waveney, and what I should say is, Aliona, you came along to our place board on the 11th of July, so hopefully you got a pretty good flavour of the type of things we're doing and the type of people we've got sitting around the table. In Great Yarmouth and Waveney, we've got quite a long track record of working well with our local partners. Everyone likes to say they're special, don't they? And we always think we're special in Great Yarmouth and Waveney because we cover 2 health and wellbeing partnerships, one in Norfolk, one in Suffolk, and that's Great Yarmouth Borough Council and East Suffolk District Council. And I think when we had the emergence of place boards, we had to work, and I had to work particularly hard with our 2 district councils and the chairs of the health and wellbeing partnerships, because there was a bit of a perception that it was the NHS parking their bus on the lawn of the health and wellbeing partnerships from the district councils. We're well past all that stuff, and now actually what we've done is worked very closely with both the health and wellbeing partnerships and indeed map the work of both of those health and wellbeing partnerships to that of place board, so we can get real benefit from the sum of the parts we've got. So as I say, I chair the Great Yarmouth and Waveney Place Board. We have Sheila Oxtoby, who's the Chief Executive of Great Yarmouth Borough Council, who's Vice Chair, and we've got good representation from all our key strategic partners. Indeed, I always think it must be a sign of success if people are asking to join. And just recently we had a senior representative from the East of England Ambulance Service also wishing to come along and join our place board. We've got a very clear ambition, which has been underpinned and driven by a robust understanding of our health inequalities, such as we know that Great Yarmouth and Waveney are off the Richter scale for some of the challenges we've got with our local population smoking, but I'll come back to that in a moment or two. So what we've done in our place board, we've divided ourselves up into some key work streams: urgent and emergency care transformation work, mental health, prevention and health inequalities, and primary care network development. But because we're rather tight on resources and capacity, because we've got a great group of willing volunteers that sit round that table, we are really focusing our work at the moment on urgent and emergency care transformation and prevention and health inequalities. Just to give you a bit of a flavour for that, we have really been focusing on things like smoking cessation and building on some of the work we've been doing as an acute trust, as a national pilot site for smoking cessation in pregnant people and inpatients. And just recently, thanks to one of the non-executive directors here at the Paget, who also works at the University of East Anglia, we've secured research funding to look at the issue of vaping in underage people, and we're working with a local school as well as the Great Yarmouth Borough Council. So you can see what we're doing at the place board in Great Yarmouth and Waveney is taking health out into the context of what our partners are doing and adding value to what we're doing at our 2 health and wellbeing partnerships. We're also working very closely with Sport England that have got quite significant funding, and it's on a place-based geography to support the high levels of inactivity we've got in our local population. So again, we're kind of like holding the hand of that, what could be a substantial and indeed massive investment of resources to help our local population get more active. I'm going to pass over to Rachel, who's going to just very quickly just talk about a couple of the successful things we've done, just to give you a flavour. They're all in the slides, which I'm hoping you've had a chance to look at. And then I'm going to come back to give you a bit of a challenge, if I may be so bold, Aliona.
Thank you, John.
Thank you, John, and hello everybody. I have just picked 2 of the examples, but there's 5 covered in the slides, and they are pieces of work or activity that we're leading and are really involving all partners through our place. So really harnessing the collaborative and the developmental opportunities that place provides. So the first one of those I wanted to highlight is something called our Health Connect service. So as I say, it's a place-led service. Health Connect explicitly supports individuals to recover following being in hospital and avoid readmission. So it's a holistic service, really understanding what matters to individuals rather than what's the matter with people. explicitly focusing on people who are leaving hospital on what we describe as pathway zero. So it's going back to their place of residence without any further support. But we've really identified that there's an opportunity in this space to ensure people do have all the wraparound support that's needed to ensure that they do continue to recover safely and well at home. The service has been operating for just over a year. And we have 4 health connectors who are hosted by East Coast Community Health, our community health provider. And those 4 individuals sit within our primary care network teams, so a key part of the primary care network, but are there to provide that sort of holistic support and being able to navigate really any further guidance that individuals need. So over the first 12 months of the service, those individuals telephoned and contacted over 5,500 individuals following being discharged from hospital. So there's a phone call at 48 hours and 72 hours later just to ensure people are being supported. As a result of that, we picked up over 1,300 people who needed further support, and quite a lot of that involves a home visit, so the Health Connector supporting the individual within their home and then ensuring that there's a clear wraparound support and making onward referrals into wider organisations. So I'd say it's massively involving all partners in place and really looking at the holistic needs of individuals to support them to stay well and recover as quickly as possible. We do have, as John mentioned, a real focus on sort of broader respiratory conditions as one of our priorities in place, and smoking is a sort of a sideline of that. But we now are in the process of recruiting 2 further health connectors with funding to sort of specifically focus on respiratory needs. So again, that's looking at the wider determinants of health of the impacts of a cold home and how that can really support individuals with long-term respiratory conditions. So that service continues to go from strength to strength and has got a real good opportunity, I think, to be understood better as to how we're supporting that sort of wider ageing well agenda. The second example I just wanted to give a quick deep dive in is something called Lowestoft Healthy Hearts. Aliona, you heard recently a bit more detail about this piece of work, and we're at the very beginning of this project. But very importantly, again, it involves all our place partners, and the launch of the project has been very heavily focused on hearing the voice of our local community, our local residents, as to what matters to them. The Lowestoft Healthy Hearts programme was born out of really a well understood and evidence-based work which has happened in Bradford. So we are sort of taking the lead from Bradford. So explicitly focused on CVD and healthy heart with a focus on hypertension case finding. So we've had a 3-month period of supporting engagement with the community via 5 voluntary sector organisations, and that then has shaped a broad approach to how we can work together across 3 identified areas to address some of the health inequalities around cardiovascular disease. One element is focused on how we can prevent ill health. The next focus area is on how we can detect, so undetected poor health related hypertension. And the third element is all around how we can protect. So it's a sort of how people who have got identified health conditions, how we can optimise their care and their health. So we have some really good innovation happening. We are looking at having a health check pod, which is called a CSU pod, being based in a local library. We are going to be having a Feel Good Suffolk officer with an explicit focus on supporting individuals with cardiovascular disease or sort of precursors to poor health. So a really holistic view, and again, very much anchored in what the community explicitly has said that they wanted. This is a health inequalities programme, so we are targeting our most vulnerable communities who sit within our core 20 communities in Lowestoft, and Lowestoft is identified as really having some really poor health outcomes, specifically around cardiovascular disease. So they are two quite different pieces of work, and I'm hoping we can come back at some point and give you more information about the success of Lowestoft Healthy Hearts. We are due to be launching the programme in September for a 2-year piece of work. So in summary, those are sort of two pieces. Hand back to John, unless anybody's got any questions about any of the other examples we included in the slides. So I'm more than happy to take any questions.
Thank you, Richard. Before we go to John, is that John talking?
That was, sorry, I'm rudely interrupting Ali. I'm excited.
I know you're excited. Just to finish on Rachel's presentation, if I may, John, please, because I have witnessed really good work happening in that place board meeting. The main reason I'm visiting all place boards is just to get a feel as to what is happening. It clearly is focused on what it should be doing, and I can guess exactly what challenge you'll give us in a minute. Completely right one to present. But just to finish on Rachel's presentation, the Healthy Hearts is very much based on community voices findings too, isn't it, Rachel? And Mark will remember every time we have community voices presentation, I'll say, so what? You ask people, so what? Now, this is a very good example of the so what. And in fact, when I saw this presentation at the place board meeting, I did say, please, can we have it in a full swing presented to the patients and communities, because that is just a very good example where we engaged and we've done something about it. So yes, we would like you to come and give us a spotlight on that particular project. I also can see Andy put lots of comments in and there's additional data you may want to look into. But now it's just to say formally a big thank you for allowing me to be party to your meeting and the other place boards who I visited too, which are running slightly different. They're all slightly different, which is something to bear in mind. But of course, the main thing is we need to address the local population needs, and that will be different. So completely understandable. But now a very good example of a very good activity on a place board, John. So over to you now before I go to Kathy.
No, and I will be quick, so I know you're short of time, but Rachel is just one of the many brilliant people we've got working in the Great Yarmouth and Waveney Place Board. So my challenge to this committee is to, can we find a way of the ICB leaning more on place, clarifying the role and responsibilities, and holding people, this is going to be a strange comment you're going to hear now, holding people like me as place chair to account for it. Now, you did say, Aliona, that there's a different approach in the places, and that's entirely right, because there are different drivers and different health inequality challenges each of our places have. But I do honestly think we now need to move into an area where we confirm what the responsibilities are, what the accountabilities are, and what me as a place chair should be held to account for. Otherwise, I do fear that the goodwill we work on may slightly start to run out of steam, because we need that mandate, that clarity of direction of travel, and dare I say it, the standing of place boards and how they're viewed by our ICB as a whole. So I don't want to stand on and finish on a negative note from me, but lean on us more, but be clear about what it is you want from an ICB perspective, us to deliver, accepting that variation.
John, thank you very much. That's exactly what I was expecting to hear. And this is the start of that journey, because up until now, the places are not reporting from the accountability perspective to many places full. But Mark, Kathy, before I come to you, Mark probably will want to just give some answers to what John just said. Mark, is that right? Yes?
Yeah, I can do, but I could have guessed that as well. But I absolutely warmly and wholeheartedly welcome that challenge, John. I think it's absolutely the right one. You know, there's a new structure that should be in place shortly. That's been put in place to try and answer some of those questions and seek support from ICB and ICS colleagues on that. But I think absolutely, I particularly liked your last slide, or your penultimate slide with the iceberg. I think absolutely. But for me, it really highlights that, you know, the power of good data, population health data, public health data, to identify what's important. You know, strong relationships across the community, strong relationships across providers, and I think, Aliona, as you highlighted when you visited, I think nowhere is that more apparent than in Great Yarmouth and Waveney. So we need to get behind and really support you, because the transformation, some of the transformation that I've seen has been truly impressive, and it's how do we build and scale as well. We don't want to duplicate everything. We don't want to do things 5 times or 8 times at a partnership level as well. But I think there's some great work there. So just to echo my thanks as well for all you're doing, and look forward to supporting you in the future world as well, John and Rachel.
Thank you. Thank you. Okay, very quickly to Kathy and then Suzanne. Yeah. We're really running out of time.
I'm okay. I'm okay because John asked my question about the enablers for change and Mark has answered it. So okay.
Thank you, Kathy. Suzanne?
I was just going to say how pleased I am to see all the in the way that this place board has really embraces prevention and addressing health inequalities in a way that I haven't seen any other do. They're truly leading the way in terms of some of the prevention activities and addressing some of the things in our population health management strategy. We've identified key priorities, and the GYW Place Board is really addressing some of these prior to this piece of work happening. And I think there's a lot more we can do going forward in terms of refining and helping place boards look at their opportunities for impact in the future. And I think that's something that the population health management team need to be helping with. So that's a challenge to us as well.
Suzanne, thank you. John, you know where Suzanne is, so when you need help, just shout for it, please. I can't see any more hands up, but yeah, well done again. Thank you. I will be visiting you again. It's just good to know where we are heading so I can support the system in my role, but also to know what questions to ask to keep it to that scrutiny you're after. So thank you, and thank you to the team in the background, and we'll look forward to hear from you again in the near future. Thank you. Okay. John Pant, patiently waiting, I'm sure. John, are you there?
I am here, Aliona. Yes. Yeah. Would
Thank
you like
you.
me to go over my bits?
Would you mind? And I feel like I apologize to you every time you bring a report. But John, we have read the paper. So please, can you highlight the key points so we can have a targeted discussion, please?
Yes, yeah, absolutely. Yeah. So thanks to everyone for the opportunity to come and talk to you a bit about complaints that we've received. Actually, as we're now rebadged as a patient experience team, which I've highlighted in the report, and previously we were the complaints and inquiries team. The paper itself highlights actually the continued trend of high volume that the team has experienced, and it states that it's higher than in previous financial years, but actually that's, I think, just speaking frankly, that's no surprise at all, given the delegation of pod complaints from July 2023. So what I would say is next time I come before you, we'll have some proper year-on-year comparison, which I know Frankie had highlighted at the last committee she was keen to have. I just wanted to kind of really just give some context around that, because some of the increases in volumes look pretty wild. But actually, you know, we're talking about, you know, 2 completely different periods in terms of what we are actually handling and the staffing model as well. So yeah, as I say, from July 2024, we should have a real much better handle on year-on-year comparisons. As you can imagine, given the upturn in volume that has predominantly been around primary care complaints, a lot of the trends highlighted in the report are within the primary care settings. So we're looking at delays in treatment and the type of care that's been delivered in general practice. Something that I've brought, I think, to most committees is access to dentistry. And I think what we're seeing now is it's more access to routine dentistry, because the impact of the urgent treatment service is being felt across the system. So we're receiving much fewer contacts actually about people in dire need of assistance, which is, you know, is signs of progress. But the one thing that I really wanted to highlight here is actually around diabetes funding, and with the new technologies that are being rolled out. I think this is something that the ICB is going to receive plenty more contacts around moving forward, purely because of the NICE technology appraisals and the kind of the rollout of those, and the fact that the ICB's position and perhaps the position of the acute hospitals that are prescribing these devices, and perhaps potentially as well positions of different systems across the country, all just seem to vary ever so slightly. So as a result of a lot of this feedback, we are working on being much tighter on that. But I just think it's a trend that probably is going to continue moving forward. There is, and I know Aliona, you were keen on seeing this, so there's a bit more in terms of the individualized learnings that are detailed in this report as well. So some real tangible stuff that we've put in there. Mm-hmm. And what I've also highlighted is the future of the patient experience team, predominantly because, and I think it's a legitimate challenge that when I come to this committee, we get a lot of, so what next? So actually you've got all of this intelligence, but actually what changes as a result? Mm-hmm. And I think because of the aforementioned upturn in volumes, we haven't been able to do as much as we'd have liked with that. But given the ICB's executive management team has signed off on us actually being able to do something slightly differently with the resource we've got, once we get that in post, I'm really confident that we can start working with system partners to better triangulate information. And having had some preliminary chats with them already, I think we're really going to be pushing on an open door. I guess now that is with acute providers and community service providers. I think the challenge, as I might have said here before, is going to be capturing that intelligence in primary care, because you're looking at 105 different practices, general practices across Norfolk and Waveney, plus the dental practices, plus the pharmacies. It's how we kind of bring all of that intelligence together and put it into something meaningful. But that's quite aspirational, but it's good to be aspirational, and yeah, hopefully we'll get moving on that over the next kind of few months. So that is me, Aliona. I'm really happy to answer any questions. Sorry.
John, thank you so much, and as always, detailed and very clear report. And I'm very pleased to see that you already are now the pressure on the team and so on, and you haven't quite got the resource, but you're already starting to implement some of the things after, and the committee is after. So thank you so much to all of you. Very small practical question in relation to the difference in numbers. I appreciate about the primary care. Maybe from the top of your head, you may not be able to answer the question, but if you are to strip off those complaints, how do we compare for the same period to last year?
So it's a tricky one to answer. Overall, it's broadly similar if you stripped out primary care. However, it depends on the reporting period, because what will happen is with regards to COVID and the vaccination programs is we'll also receive a glut of inquiries or complaints around those particular programs. So it depends on when they're executed, which is why it's not really an exact science. But yeah, to answer your question, broadly similar.
The other thing, John, is I completely understand the issue of 105 practices. And of course, there'll be patients who never spoke to their practice. So they'll come to the ICB, and then you have to go through the whole chain of, and it's not an easy task with so many independent providers. Technically, that's what it is. Is there anything this committee can do to support the work of your team in terms of then engaging with the practices or the network they may have? Or is there anything we can take through the primary care committee again to support your team and making sure that we're actually engaging with those practices and help them address some of the issues patients are or members of that community are highlighting to us? So I'm reversing it now. Is there anything we can do to help you? And
I can probably reverse it back on you actually, Aliona, in terms of, so maybe we're having a sophisticated game of Uno here, but what I would say is that we, so I went to primary care commissioning committee last month, I think. I don't know. Anyway, the last time primary care commissioning committee was there, and the LMC highlighted similar challenges about getting into general practice. I've met with Lisa from the LMC, that was last week, and we're having conversations about members of the complaints. Well, sorry, I keep saying complaints team, patient experience team, attending the practice manager conference, which is going ahead and hosted by the LMC in October, which we think will then be kind of a real nice introduction, and then hopefully be able to get into primary care networks with something a bit more bespoke, because I think the ask from primary care was maybe we need a bit more support with complaints and complaints handling, but actually there's not a one size fits all with, as you say, 105 different independent contractors, and also the dental committees. I have also, and this was some time ago, had a conversation with someone at the UEA was it the UEA? No, there was sorry, it was the local dental committee, and they were talking about trying to get us in front of dentists as well to assist with that. But actually, I think the challenges aren't necessarily around the care that's being delivered in dentistry. It's more about the access to it as it stands right now. So that might morph over time.
Lovely, thank you. Completely agree with Frankie's comment in the chat. You know, it's good to see some linkages, more linkages now taking place. So, John, we're here as a committee to support your work too. We want to make sure that our residents are getting the right care in the right place and so on. We all know that. We just need to make sure it does happen. So, please, when you need, seek support from us and see how we can help you with that. Otherwise, thank you very much to all your team for handling all the complaints and resolving them for people. And I hope we manage to resolve as many as possible. Yeah. So thanks so much. I think we'll see you briefly in a part 2, won't we? Yeah. Yes. Lovely. I can't see any more hands from anyone, so I would take it as there's no questions. John, thank you, and see you shortly. Thank you. Frankie, I think we're coming over to you now for the update from the Population Health Inequalities Board.
Yeah, thank you, Chair.
Thank you.
So the first thing to say is that we don't have any new escalations or any new risks this month, which is good news. A few points for assurance. The first thing, we've talked a lot about the strategic framework for action and the population health management strategies, and they are both now fully published and in implementation phase. So that's the first thing I wanted to raise. Secondly, our population health management software is absolutely crucial to let us do the job we need to do. And so I'm pleased that procurement is well underway now. And we have 6 suppliers interested, and so that formal process is ongoing. And then thirdly, we have some good news. We have appointed Shelley Ames as a new Health Inequalities and VCSE manager. And with her coming on, I'm sure that is going to strengthen our VCSE working, but also just to draw the committee's attention to the fact that we've changed the governance around how VCSE is sort of pulled into the fold. And then finally, really, I've given a few examples in the report, which I hope demonstrate both the scale and the scope of the projects that we're leading here. So in terms of the scale, just pulling out the diabetes education programme, 27,000 texts have been sent as a part of that. And in terms of the scope, we talked earlier about lowest of healthy hearts, but looking at the warm homes initiative and the weight management initiative, some really, really disparate pieces of work, but all very much there to tackle health inequalities and to improve the health of our population. So that was all I wanted to pull out, but very happy to take questions.
Thank you, Frankie. May I have one, please? Equality impact assessments. Is progress with that piece of work? Do we know when we're going to have the process in place? Just as target date?
Tracy, do you have a feel for the date? Yes, I know you've been leading that work through the HI team.
Absolutely. So I've got a meeting this week to finalise with the PMO team who've been supporting us with our internal process for that. We combined it with the equality impact assessments with the quality impact assessments, and I know that Karen and Tricia, we will be having a kind of panel that's going to review some of those. So that process is all kind of being finalised. I think you've had a paper at EMT, so I've got my final meeting with the PMO team this week to really finalise that, and we do plan to bring an update to PHNI board as well at what that process is. So we're well underway now.
Nearly there. It has been a huge piece of work though, and as soon as we lifted the lid on it, we realised just how big it was and how disparate and different QIAs and EQIAs have been undertaken, and they haven't really had a home and they haven't really had that proper scrutiny and oversight. So I think it's been worth spending a little bit more time over it.
Excellent. Well done, and thank you. And Frankie, thanks so much for adding the risks the way you did. That's exactly what I was looking for when we originally talked about it. So thanks so much for doing that, and it's very clear and will enable the committee to ask any questions around those. So thank you indeed. I'm looking for any hands. Any more questions from anyone? No, I can't see any. Frankie, as always, thank you and keep up the good work, you and the team in the background. Yeah, we'll look forward to the next progress, but well done indeed, and thank you.
Pleasure.
Okay, so I think it's last but not least is the Aging Well Program Board. Frankie, are you introducing or Janice is starting?
It gives me a great pleasure and pride to ask Janice to share an update. Last month, at the last meeting, we had a sort of an assurance report as to the whole of the work of the programme. Yep. This time you've asked us to give a sort of a deep dive on the dementia aspect, and so Janice will share that. But I would be grateful for a steer from the committee as to how you would like the regular reporting from this programme to come. So for the PHM and Health Inequalities, we just bring you a report every single time. Now, there may not be very much to report if we bring it every single time, but on the other hand, I think for outside this meeting, we need to. It would be useful to have that clarity. But for today, we're just going to talk about dementia. So, Janice.
Thank you.
Hi there. Thank you. Thanks for giving us the opportunity to update you. I'd also like to introduce our new colleague, James Allen. James has recently joined us as the Clinical Programme Manager for the Aging Well Dementia Palliative Care Programme. So he's got quite a lot on his plate. So welcome, James. Obviously, I take it the paper is read, but just to sort of like point out some key points, we're very lucky to actually have such strong VCSE support for our project, and we've actually got representatives from the Later Life Network attending our 4 work streams. So we're really grateful for that opportunity to get their knowledge and experience. We held our first work stream for dementia on the 8th of July. And we had good representation from across the patch. At the time, we didn't have our clinical leads on board, but we have now appointed specialty advisors to consultant geriatricians from the QEH, James Casson and Katie Honey, and they're both going to be joining us as the specialty advisors for Aging Well Dementia Frailty. So just generally with regards to this dementia workstream, I've put the details in the report about the areas that we're looking at. I think we should note that this is actually a long-term project, so it's spanning 5 years. So although we're really keen to get work going as quickly as possible, and we've highlighted 7 key areas where we want to focus our attention, we've got to be really mindful of the fact that it's a marathon, not a sprint. And we just have to sort of like focus our time and effort and pace ourselves over the next 5 years. But we will actually be sort of like linking more with our carers, patients with dementia, and our key stakeholders to identify what is the key priorities for them. You know, what should we be tackling first? So that be part of our work plan, is to get that out there to the wider stakeholder community, just to sort of like get some more feedback on what areas we need to focus on. Currently, our main focus is on the Dementia Charter, getting that signed up by all the organisations. We've got we just have one outstanding at the moment, but they do have it on board and they are filling in the self-assessment form as well. And again, we are asking each organisation to complete the self-assessment tool so that we know where the gaps are, so that we can prioritise the training, education, development, and also sort of like see what other steps need to be taken to improve the care for the patients. Just generally, we welcome the support that your committee will give us to actually improving the care for our dementia patients. So thank you.
Thank you, Janice. Well, I was privileged to sit in one of those meetings. Can reflect on some of that in a minute, but I'll go first to Karen and then Kathy.
Thanks so much, Janice, and it's really pleasing to see the level of detail. I think for me, the most thing, one of the things I'm really happy about is the carer involvement, because without the carer engagement, it's going to limit somebody's independence at home. And just even having simple guidance advice makes a difference between being able to carry on and not. And that's lived experience for me. Thank you.
Thank you, Karen. That's so important. Thank you.
Thank you. Kathy.
Thank you, Janice. I was just wondering about the take-up of the training from the Alzheimer's Society, and I think it's been going since 10th of July. Do you know what the take-up is from primary care?
I don't know off the top of my head. I'm putting James on the spot here as well. Do you know, James?
No, we don't get the immediate feedback on that, but I can take that away and feed back to the group. Not a problem.
Okay.
But no, I think it's being collected externally directly from us. I can find that information and send that back to you, Kathy.
Okay,
Great.
that's great. Thank you. I'm hoping they were really keen.
They're oversubscribed rather than unsubscribed.
Yeah.
Hmm.
Yeah.
Thank you, James. Thank you, Kathy. Frankie.
Yeah, just picking up on that. So when we sort of inherited the dementia work stream, which had previously been led by the Mental Health Collaborative, there were three streams. There was that leadership, which was the charter. There was the education piece, public education, patient education, care education, but healthcare professional education vitally. And by that, I do mean care as well. So care home staff and others, not just our NHS providers. And then the third aspect was the data and digital. But just to flag although people understand and are keen on receiving the education, actually we have hit a bit of a bump in the road. So the one of our providers that has not signed up to the charter has not signed up because they're worried about the time commitment that it would take for their staff to undertake the training that we are recommending. So that is the reason why one of our providers hasn't signed up yet, even though we would argue, well, actually, this is vital, and invest this time now, you will save time and clearly improve quality of patient and carer experience later. But I think it is worth noting that.
Yeah, it's disappointing. Yeah.
Well, it is. I was just thinking about mandatory training, because CQC providers, there's a good list of mandatory training, and dementia awareness, I think, is one of.
Yeah, we're not talking about mandatory training. And the issue with making everything mandatory is if you keep on adding things to the mandatory training list, you'll actually you'll push down compliance. But we're talking about quite extensive training. It's quite a significant time commitment.
Okay.
But perhaps it might be worth this committee bearing in mind that one of our providers hasn't felt able to sign up, and perhaps giving a little weight to my persuasive tactics wouldn't go amiss.
Thank you, Frankie. Let's think about that one. Tricia.
So we should be strongly recommending.
Yes. Thank you.
Now, from the perspective, however, of the training programme, and I get it with all of the strike action, etc., that they might be scared. But is there the opportunity to think of key areas within the trust as a starter for 10 and then go for a wider rollout? And that might be a little bit more of a negotiation position, just thinking it through.
Yeah, absolutely. The charter doesn't make the expectation that you'll do everything on day one.
Okay,
it's just that you will commit over time to the principles within it.
In a way, it's even more worrying, Frankie, because if it's the commitment, why wouldn't you sign? Because you can then plan how you honor that commitment. Yeah. Janice.
I'd just like to add that although they haven't signed, they have actually provided representation at the group and are fully on board with delivering best practice principles and working with us. But as you say, it's just that adherence to the mandatory or the training that is an issue.
Most challenging.
Thank you, Janice. I had a question about the charter, because if I may have misunderstood it, okay, so apologies if I did, but from what I understood, it is that it's signed by predominantly statutory providers. Now, in my head, there's provision happening within the voluntary sector. And of course, we know that those who are working with older age will have quite a large cohort of those people. Now, was there a reason why we're not expecting the voluntary sector providers to sign up to the charter?
I'm not sure of the reasoning behind that, but I don't see if there would be any reason for our other providers to sign it.
We decided to start with the statutory providers, but we have, and in fact, I think we already have some signatures from other providers, but we wanted to start with the statutory. But we are very keen for other providers to sign up to it as well, but we wouldn't sort of hold them to account to it.
So am I, Frankie. So I'm wondering if we go to the later life provider network and just take the charter there and ask the members to consider and sign up to that, because that would be one good way for them to go through. If that's
I I think that's an excellent idea. Should we take that as an action, Janice?
Yeah, definitely. And also
Thank
we
you.
can include it in the contract negotiation rounds as well. That we can put it as one of the key documents that we have in the contracts pack for all our providers.
Good thinking. Good. Any other questions for Janice or James or Frankie? We are at the beginning of the journey. I know you just inherited. There's plenty of work to be done. I know that. And it's good priorities. So let's hope that we can start segmenting it and have it in manageable chunks so we can actually achieve rather than demotivate ourselves without, when you go for everything and not much is happening. So well done with where you are and really good luck at getting this to the next stage. But yeah, let's involve as many people as possible to support you and delivery of this. So thank you and well done indeed. Thank you. Okay. I think this brings up, Mark. Do I have a delay in my thinking? Because if you had your hand up before.
No, it's fairly recent one. It's fairly recent.
Sorry.
So, and if I may, I just to introduce Councillor Liz Withington also, as well as the kind of ageing well work in the wider piece, we've also done a lot of work in the North Norfolk place, and Liz and colleagues have done an awful lot there. So just if okay, would like to introduce Liz just to say a few words, because there's things we're doing strategically, but actually it's around people and families and carers, as many have highlighted. So Liz, just wondered whether you would like to come in and say a few words, but don't feel you have to, but I think it's important. Thanks.
Thank you, Mark. Thank you.
No, I'd love to come in. I'm Liz Withington, as Mark said, and I'm a district councillor at NNDC and chair of the North Norfolk Health and Wellbeing Partnership, very new in role. But I've been involved in the dementia work that's been going on with the working group. And I think probably the most significant thing is the identification of a pathway and trying to identify a route and what input is needed from both statutory and VCSE organisations along that pathway, and making it so that not only our NHS partners and VCSEs know what that pathway is, but that carers understand that pathway as well, so they know where to go at different stages in their journey. And I think that's probably the most significant strategic thing that we've been involved with. It's sent off lots of offshoots in different directions about different things, but that's the main focus of what we've been looking at, and hopefully that's coming forward now quite nicely.
Thank you, Liz. Isn't that one of the... No, probably not. Frankie, you mentioned sits in one of the 7 priorities we have, somewhere in that, the carers' involvement.
Yes,
It's very much part of the plan.
And actually, I just popped in the chat. We actually had a presentation from the North Place Board at our last Ageing Well programme to really look at the broad, not just the dementia work, but some of the work going on in North is really great, particularly on falls prevention.
So, Liz, I think it will be very welcome to have the input and the expertise. Yeah. So please keep in the loop, so to speak. And Mark, really, my apologies. I misunderstood. I saw James stepped in instead of Liz, so I just didn't get the dots connected. So apologies for that. But Liz, I think I heard at the North Norfolk Place Board I went to, didn't we, Mark? We did talk about it. So yeah, indeed, lots of good work is happening, and thank you so much for sort of leading in that area and delivering on the ground. So thank you, but please keep in touch with Janice and Frankie and whoever else is relevant to make sure we actually connect all the dots and don't do my mistake I just did. So thank you so much. Any other questions from committee members to Liz or to Frankie or to Janice or to Mark? No, I can't see any. Well, thank you again. Any other business? No, negative nods. So look at this. Somehow we managed to finish in time. We're literally taking 30 seconds for switch over, but I would like to thank you everyone for today's contributions, for your partaking in the discussions. We want to have those discussions constructive and actually, something we can be proud of, that we're taking things forward. So well done to all the teams for all their work. That includes all providers who are party to this meeting. So thank you again. And until the next time, which I think is on the 23rd of September. Yeah, good. Thank you. And I will see the committee members only in the next minute. We need to relog. Thank you. Bye-bye. Bye.